Good afternoon, everyone. Just going to get one more minute to help people get settled and logged into Zoom, but this is Carolyn Mullen. So excited for everyone to join us today. Great. Well, it's 3:01, so let's get started. Good afternoon, and everyone, and thank you all for taking time to join this first event in the Coalition for Health Funding's first ever Public Health Week of Action. I'm Carolyn Mullen, President of the Coalition for Health Funding and Senior Vice President of Government Affairs and Public Relations at the Association for State and Territorial Health Officials. Before we begin, I want to go over a few housekeeping items. Because we are using Zoom's webinar platform, all audience members are muted throughout the discussion, but we will be taking questions at the end. To ask a question, use the Q&A function to type it out. You can submit questions now and throughout the presentation. When submitting a question, please include your name and the full name of your organization or congressional office with your question. The Coalition is pleased to welcome our distinguished lineup of panelists. Thank you all for being here and for sharing your expertise on improving health equity and the impact of social determinants of health. As you all know, this topic is important more than ever as we continue to battle COVID and continue to witness the disproportionate impact that pandemic has had on vulnerable communities. This is why the Coalition for Health Funding decided to focus on health equity for our inaugural Public Health Week of Action. Central to our mission is working to ensure all Americans, regardless of race, ethnicity, and geographical location, have the tools available to them to lead long, healthy lives. Many of our member organizations, not just those represented on our panel today, have been working on important initiatives to help address social determinants of health and promote health equity beyond just the pandemic. We have created a publication to showcase these efforts, which you can find on our website, publichealthfunding.org, and link to it posted in the chat. I encourage everyone to take some time to look at this important resource to learn more about the impactful work our members are doing and what Congress can do to help. Before we turn to our panelists, we are excited to have remarks from Representative Lucille Roybal-Allard of the 40th District of California, co-founder and co-chair of the Congressional Public Health Caucus. We are also excited to be able to continue to work with Congresswoman Roybal-Allard and are grateful for her tireless work towards ensuring that all Americans have high quality care they need to live healthy lives. We are now turning to a video. There we go.
Hello, everyone. I'm Congresswoman Lucille Roybal-Allard, and I am so pleased to welcome all of you to the first and hopefully annual Public Health Week of Action. I most sincerely thank the Coalition for Health Funding for organizing this event, for its decades-long dedication to highlighting the importance of public health funding, and for helping to sustain critical investments for our nation's leading public health agencies. CHF's education and advocacy, including the wildly successful public health fairs, which we all enjoyed in pre-COVID years, have played an important role in strengthening public health research, preparedness, and the public health workforce. As co-founder and co-chair of the Congressional Public Health Caucus, I have long believed that public health is the most cost-effective investment that we can make as a country. In fact, throughout the last century, most of the major improvements in the health of the American people have been accomplished through public health measures and interventions such as immunizations, smoking cessation, and the nutritional supplements. But as we saw during the COVID-19 pandemic, chronic underinvestment in public health and prevention can have a devastating impact on our ability to rapidly mobilize against an epidemic or an environmental threat. And sadly, we also learned that vulnerable populations pay the highest price for poorly invested public health systems. In this wealthiest of countries, I believe that we have a moral imperative to ensure that no one's life expectancy is determined by the color of their skin or the zip code in which they are born. As past author of the Health, Equity, and Accountability Act, I understand that eliminating health disparities is essential if we are going to improve the health of all our communities. That is why I continue to fight for robust investments in community health centers, funding to expand access to mental health care, and adequate support to expand the size and diversity of our healthcare workforce. But to truly achieve health equity, it is imperative that public health embrace a commitment to improve the social and economic factors that influence people's health, including affordable housing, educational opportunities, and violence-free communities where families can thrive. I commend all of you for focusing your attention during this Public Health Week of Action on the intersection between health equity and social determinants of health. I wish you an invigorating and successful week of discussions and strategizing. I know that the Coalition for Health Funding will continue to play a vital advocacy role for funding public health research, preparedness, and the public health workforce. Thank you for inviting me to speak today. I look forward to continuing to work with all of you to ensure a robust and successful public health system in America.
Wonderful. Thank you so much, Congresswoman. Now I'd like to briefly introduce our panelists, and we will turn to each of them for an overview of their organization's work to address social determinants of health and health equity. First, Dr. Kim Johnson is the Senior Director of the African American Health Equity Initiative at the Susan G. Komen Foundation. Second, Montrese Ransom is the Director of the National Coordinating Center for Public Health Training at the National Network of Public Health Institutes. Nicole Sereno is the Director of Health Equity at the American Psychological Association. Dr. Jennifer Holter is the Chair of the American Society of Hematology's Committee on Government Affairs and the Associate Professor at the University of Oklahoma's Stevenson Cancer Center. And Dr. Philbert Alberti is the Founding Director of the Association of the American Medical Colleges Center for Health Justice and the Senior Director of Health Equity Research and Policy. Dr. Johnson, take it away.
Thank you so much, Carolyn, and thank you so much for having me here today. If I can cue up my slides. Okay. Well, thank you, and greetings from Susan G. Komen. I am Dr. Kim Johnson, Senior Director of Komen's African American Health Equity work. First slide, Lindsay. Our health equity work, focusing on the Black community, is really the landmark of Komen's work in terms of health equity in the Black community. And the initiative is called Stand for Her, her being an acronym for Health Equity Revolution. The initiative aims to reduce breast cancer disparities in the Black community by 25%, starting in United States metropolitan areas where the disparities between mortality and late-stage diagnosis between white and Black women are the greatest. And if you can see this slide, you can see those 10 large metropolitan areas listed there, both starting on the East Coast and extending all the way over to Los Angeles in California. The initiative, in Stand for Her, actually focuses on a myriad of services, including patient care services such as screening and diagnostic services, patient navigation services, treatment assistance for persons who are living with breast cancer or metastatic breast cancer, as well as improving the quality of breast cancer treatment in the Black community through a partnership with the American Society for Clinical Oncology, as well as genetic counseling and testing, education, and genetic counseling and testing services. And all of these interventions, all of these public health evidence-based interventions really are birthed out of research that both Komen has done in most recent years, as well as other research in terms of what are effective interventions for reducing oncology disparities, especially in communities of color. And here that would be in the Black community. Next and final slide. And so what Komen has done over the past 2 years, we undertook a 2-year research study to really look beyond the late-stage diagnosis and mortality data to really better understand the lived experiences of Black women or Black persons with breast cancer in each of these 10 metropolitan areas. We were able to rely on a combination of both qualitative and quantitative data, including engaging more than 700 community members, as well as healthcare providers in both focus groups discussions, as well as key informant interviews, and aggregating more than 96 data points in each metropolitan area. And some of those data points include some of the social determinants of health as you know them, including things like transportation and housing, access or proximity to care and to quality care, food security or the lack thereof in each of these communities. We looked at mental health issues and really used to quantify that the number of mental health days Black women and Black community members were taking due to breast cancer and their diagnoses, as well as SNAP and EBT benefits. And so the lens we used was really one, using social determinants of health. We also used the lens looking at systems level thinking or a systems level approach, whereas we looked at what were some of the micro level findings, what were some of the meso level findings, and what were some of the macro level findings. So the study that we did over 2 years, we just released on August the 4th of this year. That study is entitled Closing the Breast Cancer Gap, a roadmap to saving the lives of Black women in America. And this report really does detail in these 10 large metropolitan areas that Black women experience higher rates of death from breast cancer due to a combination of factors, including barriers to early diagnosis, also including the aggressive nature of certain breast cancers that are more prevalent in Black women than other women, including triple negative breast cancer, for example. We also found that one of the factors was systemic racism in our systems, discrimination, and lack of access or disparity and differences in access to quality care and treatment services. As I mentioned, when you look at this through a systems level framework, the barriers we then characterized as micro level barriers or personal barriers. And one example of that from our findings was financial toxicity. We found that a much larger share of Black women with breast cancer experience a negative financial impact, and these gaps remain large when you control for social and economic variables. And we found that Black women are nearly 3 times more likely to forego prescription medications or filling those prescriptions, and much more likely not to see a doctor than white men and white women because they simply can't afford it. Another set of interesting findings is at the provider or health system level. That's at the meso level in systems thinking. And one example of such finding was the racism in healthcare or in the healthcare system we found. The experience of racism, bias, and barriers in the healthcare setting is felt by Black women across the country, despite our level of income, despite our educational status, and despite our insurance status. Participants that we talked with through focus groups and interviews noted that they feel that they're treated differently in the healthcare system, and it's because of their races they're feeling, and the perceptions that their providers have about them due to their race. What's most interesting here, especially for this particular audience, would be those policy or macro level barriers, one of which is underrepresentation of Black women and others in research. Cancer among Black women, as you know, has been understudied, and Black women are underrepresented in research, including clinical trials. For example, breast cancer screening and clinical care guidelines are often created without considering diverse patient groups, and that would be often created without considering the Black community. One thing of interest to this audience would be then regarding screening and diagnostic studies. The Federal National Breast and Cervical Cancer Early Detection Program requires states to contribute funding to their state programs. Yet we found that many states, especially those that we are targeting in our targeted cities, that are experiencing high rates of breast cancer disparities in Blacks, are underfunding their programs. The National Breast and Cervical Cancer Early Detection Program is a federal-state partnership that serves a critical safety net for many of the underserved in the Black community. But unfortunately, at its current funding levels, the MBCEP serves fewer than 15% of estimated number of eligible women for breast cancer screening services. So our real ask here, our real call to action is really to ensure adequate funding for NBCEP, and it's key to guaranteeing that low income, that underinsured, that uninsured persons, members and women of the Black community across the country continue to have access to vital screening services and health education, as well as navigation services. Thank you.
Thank you so much. I'd now like to turn it over to Montrese.
Thank you for that. I am going to hope that I can present without my mask for a little while and that you all can hear me fine. My name, again, is Montrese McNeil Ransom, and I serve as director of the National Coordinating Center for Public Health Training within the National Network of Public Health Institutes. As a National Coordinating Center for Public Health Training, we serve as the voice of the 10 HRSA-funded regional public health training centers, and our mission is really centered on advancing the capacity and increasing the competency of the 21st century public health workforce. I've been in this role for almost a year now, and I've been asked often about my vision for the future of public health. And as I see it, I see a workforce that can work collaboratively across disciplines and across sectors to address all of the social determinants of health, including, as was mentioned, racism and bias. I see a workforce that's prepared to apply health and racial equity principles to each element of public health and clinical practice in order for us to reduce the racial health equity gap. I see a workforce that is prepared to step into the muddy waters of public health advocacy around issues that might fall outside of the scope of traditional public health. Because as the pandemic has taught us, we don't have the luxury of assuming we'll get the resources we need or see public health laws passed simply because we present sound scientific or public health data. Change happens. These declarations of racism as a public health crisis have happened because of social movements, because we've become better at articulating economic implications, and because of pressure. I see a workforce that's poised to collaborate in radical ways and who, due in large part to the pandemic, is empowered to help us reimagine the discipline of public health and what it asks of us in a post-COVID world. From an NNPHI network-wide perspective, the inequities and health outcomes that are driven by racism and unconscious bias and other systemic drivers of oppression, they continue to challenge our work within the network and our partners and our member institutes. We all know, hope you guys can hear me okay. We all know that racial health disparities and poor health outcomes are preventable. But state and local public health departments cannot do this work alone. Public health as a field cannot do this work alone. Achieving health and racial equity throughout the nation will require increased multi-sector, multidisciplinary capacity building, and a stronger infrastructure at the community level. And that has to be supported by sound national health policy, including appropriate, sustained appropriations for public health. So what is NNPHI doing? Well, last summer, along with the American Public Health Association and a growing list of states and local jurisdictions, NNPHI declared what we've known for a long time, that racism, not race, but racism is a public health crisis. But we know that a declaration without action does more harm than good. So to walk our talk, we're developing policy and program interventions that normalize these conversations around racism as a public health crisis, that work to promote healing and advance truth and reconciliation in this work, that move toward eliminating racism and achieving health equity. That's the goal. As an example of our work, we've established 2 national communities of practice work groups focused on health and racial equity. One is focused on internal policies and best practices that our member institutes and our partners can implement to pursue increased equity within their organizations. The second is a group that's working to compile strategies to address external drivers of racial inequities in response to our long-term recovery from COVID and moving into what may be the next pandemic. Our goal is to reimagine a more equitable, more just society. Our partners in the regional public health training centers have a race and social justice work group, which is focused on creating a health and social justice competency model that we hope will be used by all of us to help better ensure that our training and that our workforce development initiatives moving forward not only center health and racial equity, but are based in established or emerging equity-related evidence-based competencies. Other national efforts that we at NNPHI are leading include a project with the Office of Minority Health to establish a national coordinating center for health equity and policy. Another project in partnership with CDC is focused on national infrastructure for mitigating the impact of COVID-19 within racial and ethnic minority communities. And we're also working in collaboration with CDC and our member institute, 7 Direction, on a project called the Indigenous Social Determinants of Health. Internally, NNPHI is on an active, purposeful, intentional journey to become a truly anti-racist, multicultural organization. We're doing the work. In fact, building capacity to achieve health and racial equity is a primary goal area of our strategic plan, what we call NNPHI 4.0. And to operationalize this vision, we're investing in team learning and experiences that include facilitated racial healing dialogues internally. We are purposely designing our equity footprint and implementing an equity audit and helping others do the same thing with a goal of establishing indicators that'll help further diversify our team and our organizational capacity to eliminate inequities in health outcomes. And as mentioned, we're helping others in our network do the same, to ask those hard questions. We're forming new partnerships with Howard University and other national organizations working to advance equity in communities of color. And we're also super excited to announce that Dr. Sabrina Selk will join NNPHI as our new Director of Health and Racial Equity on December 1st. She comes to us after serving as the Director of the Office of Health Equity with the Massachusetts Department of Public Health. And we can't wait to learn more about her vision for leading and coordinating NNPHI's health and racial equity portfolio. The reality is, in what we're learning in our response to COVID and in leaning into this work around racial health equity, is that the majority of the federal funding that we see continues to be very siloed by disease classification. And that restricts our ability to build robust, multi-sector, cross-disciplinary partnerships, what I call radical collaborations, those kind of collaborations we know are needed to change the status quo and to change health outcomes, to address all of the social determinants of health, and to build the health of entire populations. We also continue to see an overabundance of grant funding that's going directly to state and local health departments. And we understand traditionally why this has been the case. But it's common, and we're seeing this, the state and local health departments are unable to process these funds. And so there are missed opportunities for those investments to really be investments, in that they don't really do much to build the community capacity to improve health, especially if that influx of funds can't be processed and used in a timely manner. From where we sit, our system feels upside down. A better balance of public and private sector investment is needed to build robust capacity at the local level. And nonprofit systems, like those you'll hear from today, like NNPHI and others, we're nimble. We're much more effective at building capacity, effective at hiring experts, and at working across multiple sectors and disciplines. And this is what is needed. If we're really to reduce the racial health equity gap and address the social and structural determinants of health, the way we've done it will not work. Now, I know I'm singing to the choir when I say this, but we've got to seize this opportunity to build back better, to build a more just, equitable public health system. And it starts with collaboration, radical collaboration. And I think this conversation today is an opportunity to lean further into that. On behalf of the National Network of Public Health Institutes, thank you so much for your time and this opportunity for me to express our thoughts.
Great, thank you so much. Nicole.
Hello, thank you CHF for inviting me to speak on behalf of APA. My name is Nicole Sorrendo and I am the Director of the Health Equity Portfolio at the American Psychological Association. We are engaged in a ton of health equity work throughout the association, including by our Health Equity Committee, our Committee on Socioeconomic Status, and the Presidential Task Force on Psychology and Health Equity. And much of this work requires constant cross-collaboration within APA and collaborative efforts with ally organizations, disciplines, and policymakers who are equally devoted to advancing human rights. Next slide. So what are we seeing in psychology? Well, our health systems, including psychological services, has many shortcomings that need to be overhauled if we want to advance health equity. And COVID-19 has made an already broken system even worse. We're seeing a lack of access to mental health services and insufficient infrastructure for complex care. For example, while the pandemic has opened the doors for greater coverage of telehealth, many cannot benefit from it. A lack of access to technology such as reliable and strong broadband service has been a critical determinant affecting access to services. Research. Many questions still persist about how social structures and elements influence health and why they affect some people more than others. Also, people of color are still significantly underserved by research, and health equity research continues to be undervalued by funding agencies. But without this research, we're unable to identify the types of interventions that could succeed in bringing about positive, measurable change. Next, we're thinking about the workforce. There is a severe lack of diversity in the psychology workforce. For example, in 2015, 86% of psychologists in the US workforce were white, while the US population as a whole at the time was 62% white and 38% racial or ethnic minority. Given this limited representation of students and professionals of color in the field of psychology, there are persistent barriers to meeting the physical and mental health care needs of communities of color. Since 2015, the workforce has started to become more diverse, with 34% of early career psychologists being racial and ethnic minorities. So we're headed in the right direction, but there's still a lot more that can be done. Considering SDOH data collection, that continues to be an issue. Currently, SDOH data is not being collected in a consistent way across all systems so that providers, payers, and stakeholders are collecting, sharing, and reporting the same types of data. Standardized data, though, could be used to identify an individual's social risk factors and unmet needs, and then trigger referrals to social services to address those needs without additional steps by the provider. Finally, insufficient payment structures. Our current financial structures disincentivize care for individuals and lower and middle socioeconomic communities and people of color. We need federal and private service reimbursement formulas and models that support clinical practices that deliver competent and culturally appropriate clinical assessment, interventions, prevention services to diverse communities. Next slide. So as you can see, there's a lot of work to be done and APA is quite active in this area. I'm happy to share last month, APA approved new policies that outline recommendations for the future of psychology. They are APA's resolution on harnessing psychology to combat racism and APA's resolution to advance health equity in psychology. And I encourage everyone to visit APA's website and read both resolutions in detail, as APA's directorates and divisions are now under work planning strategic implementation of these recommendations over the next several years that will go far beyond. We are shifting focus as a discipline. Traditionally, psychology has focused on downstream individual behavior change, and we know that there are serious limitations to this approach. If we don't acknowledge the upstream structures that perpetuate inequity, then we cannot identify or do the work necessary to transform these systems. While intervention is clearly needed at every level, we now recognize that psychologists can contribute both downstream and upstream population health interventions. APA has also adopted an equity, diversity, and inclusion framework, which we are working to embed in all aspects of our work throughout the entire organization, not those areas that focus on health equity. Next slide. So where does policy fit in? APA has supported many federal policies that address SDOH, and here are just a few. I won't belabor this slide. Next slide. So there are many opportunities to form policy that broadens access to mental health services to communities who have traditionally been underserved. For example, we support policies that provide coverage for both broadband and audio-only services, such as HR 3447. This allows those who do not have reliable broadband to receive telehealth via audio only and have it covered by their insurance. And we support making these permanent and not just bound to the pandemic. To strengthen research, we support policies that require data reporting to be standardized across all systems and stakeholders. We support more federal research funding to come in the form of RFAs that focus on social, institutional, and structural issues and as key drivers of health outcomes and health equity, including research that utilizes population health approaches, community-based participatory research, and other culturally responsive methodologies. The NIH Office of Behavioral and Social Sciences Research and the National Institute on Minority Health and Health Disparities, for example, has released SDOH measures as part of a Phoenix toolkit, and that's something that should be supported. Finally, we support policies that increase requirements and more programs that bring diverse voices into the field of psychology and mental health. Federal agencies should include scholars from historically under-resourced communities and scholars who are knowledgeable on health equity issues to guide development of RFAs, and they should be on the advisory councils to ensure diverse perspectives are always at the table. And lastly, federal agencies should develop RFAs that promote and incentivize collaborative opportunities across historically Black colleges, universities, Hispanic serving institutions, tribal colleges, and other institutions who serve minoritized communities on health equity. Then my last slide. As I mentioned earlier, APA is engaged in a lot of work in this area, and we cannot accomplish it alone, and we certainly encourage more dialogue and collaboration and invite you to engage with us through the committee work, through the networks, and please feel free to reach out to me directly. Again, I'm Nicole Sorrento, Director of APA's Health Equity Portfolio, and thank you again, CHF, for inviting me, and I'll pass it back to Carolyn.
Great, thank you so much. Jennifer.
Hi, and thank you to the CHF for inviting me to speak today. I wanted to speak on behalf of the American Society of Hematology, for which I am the chair of the Government Affairs Outreach Committee. At the American Society of Hematology, we represent 18,000 clinicians and scientists that are actively committed to studying treatment of blood and blood-related diseases. It's important to know, obviously, that many of these, both malignant and non-malignant diseases, affect areas and populations that have not been particularly served as well as they should have. Specifically, sickle cell disease and multiple myeloma are two of such issues where we have multiple populations within our communities that we serve that are not being able to access care the way they should. We are committed to addressing and reversing these historic inequities in the hematology care and space, and supporting scientists doing also more research in these spaces that have been underserved in grant funding, and to try and elevate and diversify the voices in this population and the population that we care for. We recognize that there are significant inequities that have been described by multiple panelists, both in hematology research, but also in hematology practice and training, that need to improve the diversity of both the workforce as well as the population that we need to train and serve. We have a long-standing commitment to supporting policies and programs aiming to eliminate health disparities in the care of hematologic malignancies and hematologic diseases. Earlier this year, on behalf of the American Society of Hematology, we put out a statement addressing diversity, equity, and inclusion within the hematology research practice and training, specifically identifying the dearth of research within certain populations and certain disease processes, including sickle cell disease and in African American and Black individuals in multiple myeloma trials, that should be quite frankly, there for them because they are high populations within those particular disease processes. We are trying to help deal with some of the social SDOH and research inequities that are found in clinical care, recognizing that there is both a lack of education on behalf of our clinicians and how to appropriately speak and have conversations with patients that are culturally sensitive. We also need to diversify our healthcare workforce. Our healthcare workforce needs to look a lot less like me, quite frankly. We need to identify underlying systemic racism and social determinants of health and numerous barriers that prevent our patients from getting the access that they need. So what has ASH done? ASH has made an initiative in sickle cell disease so that we can identify the critical health disparities within this population and within this community and the inequities thereof associated with their care. It is common among ethnic groups, and unfortunately, both our practitioners as well as our trainees need better education within this realm. We need to understand that a large proportion of those patients that have sickle cell disease are covered with Medicaid and deserve high quality care. But they can't access this comprehensive care because we don't have good, high quality comprehensive care centers for sickle cell disease. Especially within this population, we recognize that those women that are pregnant and give birth with sickle cell disease have a much higher incidence of childbirth death, being 10 times more likely to die during childbirth. And that specifically non-Hispanic Black women also within that same group have doubled the mortality rate. This cannot continue, and the American Society of Hematology is focused that we need to help with this inequity. We have initiated sickle cell initiatives to support advances in research, specifically with a sickle cell disease Medicare and Medicaid demonstration process, so that we can develop a demonstration process that is in the Medicaid population on providing high quality, comprehensive care for sickle cell in both preventative and primary care settings that are enrolled in Medicaid, particularly in young adults and these pregnant women that deserve our care. We are holding briefings for education on federal sickle cell programs. And we are recommending that Congress look at co-sponsoring the Sickle Cell Disease Medication Project and Demonstration Project, that they continue to fund the federal sickle cell disease programs, including the CDC Sickle Cell Data Collection Program, the HRSA Sickle Cell Grant Program, and like I said, the treatment programs. We know that there is additional funding that is needed for both the researchers and for the patients for sickle cell research, and we are dedicated to trying to improve the quality within these populations. Thank you.
Thank you so much. And now we'll turn to our final panelist, Philip.
Great, thank you. Good afternoon, everyone. It is an honor to be here and to represent the Association of American Medical Colleges, or AAMC, and our Center for Health Justice. And of course, I want to note up front how proud AAMC is to be a member of the Coalition for Health Funding. The AAMC is a nonprofit association representing all 155 accredited US and 17 accredited Canadian medical schools, approximately 400 teaching hospitals and health systems, including the Department of Veterans Affairs medical centers, and more than 70 academic societies. And the AAMC leads and serves that diverse academic medicine community to improve the health of people everywhere. Slide, please. And given that mission, it is no surprise that we are so committed to the goal of health equity, the goal of every community beginning at the same starting line for health, with the same access to the resources and opportunities we all need to thrive. And the AAMC believes that health justice is the path to that goal. Next slide, please. Health justice is a framework, a law and policy framework, really, that says the foundation of building health opportunity are first, community wisdom and expertise, because those closest to health and justice are also those closest to the solutions to that injustice, and cross-sector, multi-sector partnerships, because the social determinants of health are the same as the social determinants of education, or housing, or employment, or wealth. We are in this together. Secondly, health justice includes a research to action imperative to make the case for policy and practice changes that will shift our communities toward equity. And finally, health justice demands that we do all of that work, how we partner, with whom we partner, the research questions we ask, the policy analysis we do in an explicitly anti-racist and anti-discriminatory way. So given that core commitment to community engagement, here's how we're operationalizing it as a national center whose members represent all communities. Next slide, please. First, through our public opinion polling, we're able to better align our work with how US adults understand and think about these issues. For example, knowing that there's broad understanding that being healthy requires more than medical care, and broad agreement that unjust population health differences exist and that eliminating them should be a US priority. Next advancement, please. That information helps us be bolder and to better understand differences between geographies, between generations, etc. Next slide, please. The other deeper way we operationalize community engagement is through our Collaborative for Health Equity, or CHARGE. And this is a resource that I encourage all of you to check out. It's open to all, there's no bar to entry. Only about 60% of CHARGE participants are from our member institutions. The other 40% are their community and multi-sector partners, and they're focused on action. They contribute to our comment letters, they write papers together, they apply for funding, and they contribute to the center's work so their community's wisdom is baked in. And a prime example of how CHARGE is our community conduit is through the development of the center's first output, our principles of trustworthiness. Next slide, please. The first 5 of which, and there are 10 that you see here. This toolkit also contains videos, action guides, workshops. It's an entire effort dedicated to helping organizations demonstrate they are worthy of their community's trust. And this whole toolkit was co-designed by the center, 9 CHARGE collaborators, and just over 30 community members from 7 geographies across the US. So if you want to partner with CHARGE, we are eager collaborators. Trustworthiness is a large area of focus for the center. Next animation, please. And other work includes our recent collaboration with the AMA Center for Health Equity on a guide to language, narratives, and concepts so that all of us can be more precise, more inclusive, more respectful, and more action-oriented in how we talk about health injustice, and therefore more trustworthy. Next animation. Soon after Thanksgiving, we'll be announcing the 5 recipients of our Building Trust and Confidence Through Partnership Award, a project funded through AAMC's cooperative agreement with the CDC. Next slide, please. Another major area of focus for the center is data for health equity, understanding that if we want to catalyze the kind of hyper-local interventions needed for health and healthcare equity, we need to do better with our data. Yes, it is embarrassing that we still do so poorly collecting race, ethnicity, and language data, but that's just the tip of the iceberg of the data we don't have in a standardized, national, multi-sector shareable way. We need social needs data for people, for example, and social determinant data for communities. And so to that end, the center held a briefing this past July. The link is in the CHF member report created for this week of action. Animation, please. We focused on this issue in recent comment letters, both of which incorporated significant input from dozens of CHARGE collaborators. And the AAMC also strongly supports the SDOH Accelerator Act as one way to address this issue. Slide, please. Our final current area of focus is maternal health equity, and there are many efforts across AAMC not limited to the center's work, including our strong support of the Momnibus Act. This reflected in the one page you see here, and this is also linked in the member report. Next spring, the center will host what we're calling the Maternal Health Incubator. This 2-day collaborative effort will bring together multi-sector experts to describe effective community-based cross-sector efforts that reduce unjust maternal morbidity and mortality. That's day 1. And then together on day 2, we'll think about the data infrastructure necessary to spread, scale, and translate those effective strategies across our communities. Advance, please, to the next animation. And the last thing I want to mention is another resource the center hopes to provide that we're currently developing, and that's a health impact assessment function, so we can take that explicit anti-discrimination, pro-equity perspective to our policy work and try to understand when a policy or regulation or proposal is announced, how that action might narrow or widen health inequities. We're working on our own health impact assessment process now by looking at the impact that paid family leave might have or might have had on maternal health inequities specifically. So more soon on that. Slide, please. Finally, I want to note that the center really aims to dig deeper and address some of the fundamental social, racial, and economic injustices that give rise to health inequities. Advance, please. And if that set of injustices is the disease, then another symptom of that disease, advance please, is the lack of diversity in the physician workforce, another core crucial commitment of the AAMC. And while that branch of social justice work isn't the focus of the Center for Health Justice, there's an entire cluster led by Dr. David Acosta committed to pushing forward on that front, and happy to discuss and connect as best I can during the Q&A. Final slide. Thank you for these minutes. There are many ways to keep in touch with the center, and better yet, to get involved with the center. Here's our contact info. Take a picture, please connect, sign up, join charge. I look forward to the Q&A and the rest of the conversation. Thank you for this opportunity, and back to you, Carolyn.
Thank you so much, and thank you to our distinguished panelists for sharing all of your knowledge. While everyone starts to think of some questions, just a quick summation about all that we heard today. I heard that racism is a public health crisis. And one of the individuals who spoke said, we must be moving to reimagine a just society. And I heard a lot of the speakers today talk about their work both externally and internally as organizations. Some common themes are diversifying the workforce, improving data, research, access to care and services, improving maternal health, and improving women's health, and addressing social and economic factors, so we can all move towards that just and equal and better health for society. So with that, I'd like to ask the panelists to take themselves, put themselves on video, and there was a first question. So would the panelists comment on ways that organizations are hoping to diversify the health workforce? Thank you, Pat, for that question. Who'd like to take the first one? Philip, it sounds like you all are doing some work on that.
Sure, I will. I'm happy to address this, and then please reach out to me and I'll make some connections. So the same AAMC strategic plan that gave rise to the Center for Health Justice is also laser-like focus on issues of diversifying the physician workforce and on creating environments of inclusion excellence. So there are other senior leaders across the organization that are focused on the Black men in medicine crisis, for example, on increasing accessibility to medical school for all communities. And I'm happy to make connections through that work as well.
Thank you. Anyone else want to respond to that question?
So the American Society of Hematology has dedicated funding to try and diversify the healthcare force in hematology, as well as try and diversify the research initiatives. We have a sickle cell research initiative and consortium that is putting money into the areas that are necessary to try and improve diversity.
Thank you.
I'll add from Susan G. Komen. Susan G. Komen is working to diversify the workforce, especially the patient navigation and community health worker workforce that works in breast oncology. We're offering, in partnership with George Washington University, online trainings, especially targeting Black patient navigators as well as community health workers, as well as others in those roles, to provide online skills and training on patient navigation in breast cancer, as well as we'll be releasing in a number of weeks, probably in just about 2 weeks, a new module we're promoting on navigating racism in a healthcare system, really targeting the patient navigator as an integral part of that interdisciplinary care team, helping to train them to better empower their patients in the Black community to figure out ways to address racism and the biases that they encounter in the healthcare system when they seek care and treatment.
Great, thank you so much. So we heard a lot about the different coalitions and groups that have come together to address equity. Can the panelists comment on collaboration across healthcare sectors, providers, payers, health centers, et cetera? Montrese, do you want to try that one?
It's loud, and I don't know that I can remove my mask. You know, within the National Network of Public Health Institutes, our member institutes, as well as our partners with the Regional Public Health Training Centers, we do work within our communities, within the regions that we sit in, including cross-sectoral. One example that particularly comes to mind where we're really trying to bring in the social determinants of health, and also use it as a pipeline. There's a project called Project First Line that CDC has funded that's focused primarily on infection prevention and control. But there's some elements, some opportunities there for us to use that as a pipeline to bring more people of color through that field as infection preventionists, to really target them in associate degree programs and undergraduate degree programs and direct them toward this area. There's also a connection between infection prevention with the work that happens in health departments and the work that happens in hospitals and healthcare systems. And so there's opportunities for all sorts of collaboration and conversations through those partnerships, for sure.
And one thing I'll add that I'm very excited about from the center side is that in January of next year, we'll actually be launching a call for nominations to a multi-sector expert partner group. I think all of us talked about these radical collaborations that Montrese said, kind of bringing different sectors together. We need to put our money where our mouth is, frankly. So we're going to pay a group of multi-sector experts representing the various vital conditions in our communities, the social determinants of health, with medicine as one voice in that chorus, to really make sure that the center's work is truly aligned from the jump with all the other sectors that contribute to the health of individuals and communities. So I think that commitment to that partnership really needs to be baked into how we develop our own work as a center, as associations, healthcare and beyond.
I'll only jump on the back of both of those qualified speakers and say too, at Susan G. Komen, we really do value cross-sector collaboration, especially when doing community engagement in these large metropolitan areas that we're engaging where the disparities are the greatest. And so we're really putting efforts forth to be on the ground and working with community organizations, community-based, faith-based organizations, but cross-sector as well. When you look at addressing social determinants of health and those as serving as drivers to disparities, you really have to bring those persons in the areas of social determinants of health to the table. So if transportation is an issue in a city, then maybe we need persons who work in transportation and lead those kind of services at the table. You know, I see a role for persons in the business sector, educational sector. We're targeting the Black community. Historically, Black colleges and universities, I heard one of my colleagues mention, clearly need to be at the table, researchers. And so not just withstanding healthcare providers across the board, but others too, who really are responsible for those social services in the community and targeting other organizations like Black sororities and fraternities and, you know, across the board to really take a look at these issues. It'll take all of us at these tables, and as Philip said, it'll take money to get this done. And so we're actually definitely doing that in our 10 metropolitan areas and value that tremendously.
Carolyn, I'd like to share. Oh.
Go ahead.
Go ahead, Nicole.
Oh, go ahead.
Nicole? Okay. I'd like to share one activity that APA has launched since the pandemic started. So at the onset of the pandemic, APA launched Equity Flattens the Curve. And this is an initiative that tackles bias, stigma, and discrimination as the root of inequities and ensures that strategies and solutions around the pandemic are delivered equitably. And so what this initiative was and continues to be is a network of behavioral and social scientists, advocates, activists, community practitioners, community members, business owners, public health professionals, and we all come together on a monthly basis to discuss issues in various communities around health equity, specific to bias, stigma, and discrimination. And the idea is that we learn from each other, we collaborate, and then we take what we learn back into the communities and into our programming.
Great, thank you. Since we do have some members of Congress on the line, I want to make sure I address a question for them and how they can improve their work. So where has Congress successfully improved access and equity, and how can those successes be extended and broadened to benefit those still in need? Philip, I see you shaking your head.
Well, the first thing that comes to mind is telehealth, right? As a critical tool that's not only played such an important role during the pandemic, but provides an opportunity to ensure access to healthcare for patients on a daily basis, right? So the potential is so great for telehealth to reach individual patients living in rural and other underserved areas, both regularly and for some, we hope, not a future health crisis. And so I think the AMC is just so pleased that the bipartisan infrastructure package that will be signed into law, I think today, includes provisions to expand broadband access across the country in support of continuing that important advance of telehealth.
Great, thank you. And Jennifer,
I just want to second that.
Maternal. maternal health. Jennifer, I just want to give you a moment to talk about what Congress could be doing more to improve sickle cell disease and maternal health.
So I think what's really important is we have to get our arms around where the problem lies and what are all the different factors associated with it. And what Congress has already done, which is absolutely elemental but extremely important, is they created the CDC project where we could collect information about all these populations and identify where the areas of need are. With maternal health, with the sickle cell disease population. And then secondarily, we have a HRSA grant where we're going through and trying to dig even deeper and understand the barriers within these communities. And I think those two big pieces were absolutely necessary for us to begin the process of really making change.
Montrese.
I just wanted to piggyback on the expanding of broadband access as one of the key promising practices that we've seen. We've certainly been asking for that, and we know that that's going to help improve access to care for telehealth and telemedicine. I also just kind of wanted to say really quickly, I'm a lawyer by training. I fell into workforce development because my interest is in the people. And throughout the years, that's what I've been focused on. But none of this happens without the law. I just had to say, law might be the most critical social determinant of health because it undergirds all of the other social determinants of health. So when we talk about cross-sectoral partnerships, we can't forget the folks that are writing, interpreting, and creating these laws and policies as well, and studying the impact of these laws and policies.
Great, and I'm going to take a moderator's privilege here and emphasize that the House and the Senate Labor, Health and Human Services and Education bill, they both have a large investment at CDC for social determinants of health, and it would be great if we could get that across the finish line, along with long-term sustainable, flexible funding for state, local, tribal, territorial health departments to help work on not only just the pandemic, but long-term infrastructure and helping address health equity across the country. Great, so I really want to take a moment and just express my appreciation to the panel today for taking time out of your busy schedule for sharing your expertise with us. And thank you to the Coalition for Health Funding and members of Congress staff for participating in today's webinar. And that's all the time we have today for questions, but I am sure that each one of our panelists would love to follow up with whoever's interested and make connections across sectors to continue to build on this work together. So thank you all so much for your participation today.
Thank you.